Assalamu alaikum. A very good afternoon to you all. I'm Dr. Atif Salim, one of the palliative care consultants at Shaukat Khanum Hospital here in Peshawar. I welcome you all to the palliative medicine session in this 22nd Shaukat Khanum Cancer Symposium. Before I start, I would like to invite my guest, Dr. Muhammad Atif Wakar. I'm very thankful to him for coming all the way from Karachi and joining us here today. Dr. Atif Wakar is consultant physician and the founding chief of section of palliative medicine in the Department of Oncology at the Aga Khan University in Karachi. He is also the program director for postgraduate palliative medicine fellowship at Aga Khan University. Dr. Atif Wakar, please. Now I'm going to invite Dr. Abdul Jalil Khan. He's the consultant family physician with over 16 years experience in the NHS UK. He's also the medical educator and involved in postgraduate and undergraduate training programs in the United Kingdom and here in Pakistan. Dr. Jalil has experience in designing and developing the curriculum for various clinical and non-clinical courses and programs. And recently he has played a major role in developing and starting the palliative medicine certification, which is running successfully at the Khyber Medical University here in Peshawar. I invite Dr. Abdul Jalil Khan. As you can see, we are all progressing from just a few consultants here in the country. Now we have got 7 consultants in Aga Khan University Hospital, and we have got 4 in Shaukat Khanum. Last year, we got the palliative medicine recognized as a postgraduate medical specialty. And this year, we have started the home palliative care services. And this is to provide physical, social, emotional support to our terminally ill patients and their families at their home in order to promote the quality of their life. This service is not a substitute to the care that we provide to our patients in the hospital, but it is an additional support. The home service that we started this year is actually very advanced in the West. They are doing a lot there. So we are going to just go through the history and the past of the palliative medicine, and in particular, the home services. For this, I'm going to invite my first speaker, Professor Ian Laurie. Professor Ian Laurie is the consultant palliative medicine in Manchester. He's also the hospital dean for communication skills and teaching, and he's the medical examiner in the North Manchester General Hospital in the UK. Over to Professor Ian Laurie.
Good morning, everyone. Thank you for inviting me to speak to you today. My name is Professor Ian Laurie, and I'm a consultant in palliative medicine in Manchester, in the north of England. The first thing I would like to say this morning is thank you for inviting me back. You can see the picture of me outside Badshah Mosque in Lahore, and that's in November 2019 when I first spoke in person at your conference. I wish I was there with you this morning. What we're going to think about during the next 20 minutes or so is, where did palliative care come from? What palliative care is and what it's not, how it's changed and developed over time, And then thinking a little bit about both the introduction and the components of home palliative care services, recognising, of course, that the speakers following me this morning are going to be talking about the challenges and opportunities for home palliative care, the future of community palliative care, and especially in Pakistan itself. So where did it all begin? I suppose the really good quote is pioneering services by enthusiastic founders, because we needed those people to kickstart palliative care and palliative medicine as a specialty. So in the 1940s and 50s, they developed an interest not only in the medical aspects of caring for dying patients, but also the social aspects as well. In 1953, The Management of Pain and Cancer, the first textbook of pain medicine, technically, was published by Professor Bonica. And then in the 1960s, there were studies on bereavement and end-of-life care at home. Dame Cicely Saunders, the founder of the first modern hospice in London in 1967, was central to this and recorded the experiences of, at the end of the day, over 1,000 patients, and looked at the relationship between physical and psychological suffering. And of course, you can see from the diagram on the right there, Cicely developed this concept of total pain, which includes physical, psychological, social, and spiritual aspects. And she was part of an international collaboration across many countries to introduce services across settings, not only in hospitals, during the 1960s and 70s. In 1974, Balfour Mount in Canada coined the phrase palliative care, and that is what has stuck to this day. And most notably, just into the 21st century, in 2003, the Council of Europe defined palliative care as an essential and basic service. But 40 million people need palliative care globally, and these are slightly old figures now. The vast majority are over 60 years old, but 78% of them are from low and middle income countries. And when we look forward, these numbers will grow. So half of all deaths, these people could have benefited from palliative care input. And a staggering 83% would be in low and middle income countries. One of the biggest studies looking at access to palliative care, which a few years old now, but the most comprehensive to date, looking at 234 countries across the world, showed that there's little or no access in 42% of countries. And even then, there's a huge number of people that have unmet palliative care needs. Only 20 of 234 countries have achieved a high level of integration of palliative care into mainstream health services. This is something we really need to think about going forward, and especially if in Pakistan you're going to think about developing your home and community-based services. So what is palliative care? I still like this definition from the WHO, but you can see that I've highlighted and read the words that are important to me. It's an approach. It's never a recipe. It's not like a surgical checklist or a procedure checklist. It's always individualized. It's centered on quality of life, and that is most important. And it's the prevention and relief of suffering. And again, we're back to Cicely Saunders' total pain model of physical, psychological, social, and spiritual care. But in essence, it's the active total care of patients whose disease is no longer responsive to curative treatment. What is not palliative care, however, is an indication of failure. Just because we are unable to cure someone's disease does not mean we have failed as clinicians. Sometimes diseases are so advanced when we first see them, or progress so quickly, or indeed, especially in low and middle income countries, facilities are not available to treat them, does not mean we have failed. Palliative care is also not terminal care. It's not just the last few days of life. And we'll talk about that a little bit more in a moment. Palliative care is not a hospice or a specialist unit or a building. It is so much more than that. And palliative care is not always provided by specialist palliative care teams, by health professionals, and by doctors. Again, it is so much more than that. So how has palliative care changed over the years? Well, the traditional model of care, one of which I've kind of alluded to, is that people would be identified as having a life-limiting illness. All efforts would be at curative care. And then when they were recognised as dying, palliative care would become involved and the person would die, and that was it. And I think we all recognise now that things are very different. So the revised model of care starts way, way earlier than that. Even when someone's going through screening and diagnostic procedures, palliative care may be appropriate for the patient in terms of symptom control. I'm thinking in my own hospital, we have a regional head and neck cancer unit, and quite often these patients are presenting, going through diagnostics, potentially facing curative treatment, but they have significant symptoms, and that's where palliative care can become involved. And as you can see from the diagram, as the options for curative care and solutions decreases, the actual need for palliative care should actually increase. We then move into end-of-life care, which may be the last year of life, the last few weeks of life, and in some cases, the last days of life. But then once death occurs, we've got a role in bereavement as well, to follow that family and those close to the patient through to help support them. So as you can see, in the course of the illness, we can be involved, not solidly perhaps, but in delving in and out of the patient's care, from diagnosis and pre-diagnosis to bereavement. So developing care at home, where is home? Home is basically everywhere other than hospital, but the principles of palliative care remain the same. Looking at how home palliative care has developed in many countries, it basically needs a public health approach. It needs to be integrated into mainstream healthcare, mainstream public health initiatives, but it also has to be included in policy as being just as important as other aspects of healthcare. Without that, palliative care can remain a Cinderella specialty, which some view as an added extra, which is nice, but not essential to fund or provide. The delivery system should be realistic and sustainable. What actually can we provide? Providing a hospice for a population is great, but hospices, by their very nature and the level of funding they require, are relatively small and reach only a few patients in terms of their inpatient capacity. What may be better is to think about what can we do to change the healthcare in terms of palliative care for a wider community, and what can we afford to provide going forward, not just one single project. And to do this, you have to actually think of recognising what we've got already, local resources, the beliefs and customs and culture of the community you're looking at, and recognising that in such approaches and providing care close to the patient's home or in the patient's home may actually save money. So the components of a home care service, actually the quote here is fantastic, that the success or otherwise is based on involving relatives, including relatives, employing relatives, as much as it is providing doctors, nurses, allied health professionals, etc. So actually, we might be talking about volunteers. We might be talking about family. We might be talking about lay volunteers from outside the family. We may be talking about professional volunteers who give their time freely in their own time. We have to be realistic as well. What is actually possible to provide in the community and at home, and what is not possible? And we have to be open and honest with not only colleagues and other professionals in tertiary organisations, but also with patients and families themselves, to give them a realistic expectation of what can be provided at home and what cannot. The barriers to providing community and high quality home palliative care is often, I'm going to take these the wrong way about in terms of education, lack of funding and support. So people don't regard education as highly, sometimes as provision of clinical care, so there's a lack of funding, but also a lack of access and opportunity for palliative care education. And we, when I was in Lahore in 2019, we were there as part of a Royal College initiative to try and provide new and additional education to interested and enthusiastic colleagues in Pakistan. The access to medications can be difficult. There can be fears relating to opioids, but also there can be regulatory restrictions. And we still find in many countries in the world, access to opioids, particularly, can be difficult. They can be available within the secondary care hospital setting, but not in the community itself. And part of that is funding, because there are, I think people try to look at all the newest, fanciest drugs for managing pain and other symptoms, when actually the traditional basic medications for palliative and end-of-life care, which are much cheaper, would be just as appropriate. Perceptions are huge, and that's both public and professionals. So professionals quite often are reluctant to discuss death, and that could be for a number of reasons. It could be because they've not been trained in such sensitive communications. It can be that they are apprehensive of how they will answer someone's questions honestly. They may be nervous that the patient or those close to them will become very upset. And also, and there's a really good paper from the Royal College of Physicians, it says talking about dying, from about 2019, which I would suggest you all read, easily found on the internet. That's Talking About Dying by the Royal College of Physicians. In that, doctors think patients don't want to discuss these topics when actually they do. There can be a reluctance to mention palliative care and promote good palliative care because palliative care is perceived as being synonymous with death and all about death. And if we think about the revised model we showed earlier, it's not. It can be at any point in the patient's illness journey. And finally, there could be cultural, societal, faith, and other influences in that sometimes a faith can, what matters most in a faith can be never to give up on life, and that life matters at any cost. And we should actually think about sensitively discussing this with patients and those close to them when perhaps the hopes of cure are unrealistic, and never ever saying there's nothing more we can do, but rather emphasising that comfort, care, and quality of life and dignity are just as important. There's been success in many developing countries, and I don't quite like that term, I suppose low and middle income countries. In India and Kerala, they integrated palliative care into primary care in 2008, very much based on a volunteer system, and was working very well. One of my colleagues in Beirut that I've not spoken to for a little while now, but was involved in setting up a community-based palliative care palliative care program, and had made significant inroads following the success of that into secondary care. In Africa, Kenya, Malawi, Uganda, again, community-based programs, which had improved access for patients to palliative care advice and services. And they had better control overall, thinking of that total pain model of physical, psychological, social, and spiritual. And even thinking of such a large country as China, there's no policy nationally or funding for palliative care, but there are 200 privately funded hospices, which is slightly different from the three examples you just mentioned. So it seems to be that a community-based approach can be successful. So what's driven this success? As I've said, a community-based approach is important. Strong family culture is a key part of populations in developing countries, and that can be utilised for the good to provide care closer to home. I mentioned public health earlier on, and what we really need is integrated governmental approaches with local approaches as well. Utilising existing resources is very important. A lot of the examples of success have done so. You don't need to build a clinic. You don't need to build a hospice. You don't need to have things in a healthcare setting. You can use any local building, whether that be places of worship, empty shops, community centres, etc. And your existing resources of people, those volunteers, family, lay volunteers, and professional volunteers. What you have to do is reduce the over-medicalisation of end-of-life care. We have to recognise where further invasive investigations or procedures may be inappropriate. And also we have to advocate for better end-of-life care in all settings. Thank you for listening to me today. In our slides, there's two sets of references. And I hope that's given you some insight into and an introduction into thinking about home and community palliative care before our other speakers. Thank you very much, and I wish you a great conference. Good morning.
Thank you. So that was Prof. Ian Laurie. I'm very thankful to him. We'll move on to the next talk. And this is going to be by Dr. Karina Mijli. Dr. Karina Mijli is the medical director and consultant in palliative medicine at St. Francis Hospice in Romford in the UK. So over to Dr. Karina Mijli.
Hello, my name is Dr. Karina Midgley, and I'm a consultant in palliative medicine in the UK. I'm delighted to be part of this symposium today, and my topic is challenges and opportunities in providing community palliative care services. And I'm going to take you through a 20-year journey of evolving services in my area. My aim is to set the scene, to introduce my service, and then to share early initiatives to enhance community support, the use of service users and professional colleagues to shape the services, and the ongoing evaluation and the development of the services, with the differences that those new developments have made. My hospice is called St. Francis Hospice, and it runs a community service, which is very typical of community services in the UK. And we are situated in outer East London, but we also serve some parts of the county of Essex, which is more rural. The catchment area was about 750,000 when I joined the team about 20 years ago, but it's now nearer to 1 million, with a significant older age demographic in the outer boroughs. And we have, as resource, an 18-bedded hospice. We have 2 hospitals, both of which have a palliative care team, which has expanded over the 20 years since I've been here. We have a fair number of care homes, and in 2004, the community palliative care team comprised clinical nurse specialists delivering face-to-face support 9 to 5, Monday to Sunday, for people with advanced progressive disease. And GPs and district nurses always were and still are key partners in our care. 20 years ago, when I started, the big national and local challenge was place of death. Hospital capacity was a huge issue. The suitability of hospital as a best place to be for people who were expected to die was an increasing question. And yet, in the UK and in our locality, almost 60% of people who were dying an expected death were ending up dying in hospital because they were coming into hospital as unplanned admissions in the last few weeks of life. Research repeatedly identified that given the choice, many people with advanced illness would prefer to die at home, not in hospital. So what was happening? We asked that question of people who had been recently bereaved, and we asked that question of our current community nurse specialists. Why are people going into hospital when they are approaching dying, and what might they need to feel secure enough to stay at home? We were expecting the response to be that there was difficulty in recognizing dying, but that actually wasn't the reason. The most important reason was that families felt completely out of their depth in the dying phase. They had almost universally never experienced dying before, so they'd never seen it and they'd never helped care in that context. And they were so fearful of getting something wrong. They felt they had no one that they could really ask unless there was somebody in the family who'd experienced dying. And they experienced uncertain support from the GP in many cases. So we scoped existent models across the country. What had people put into place to try and meet with the challenges of this scenario? And we looked at our resources. What had we got? What did we need to help us care? And what we figured was that often what was needed was probably quite uncomplex. It was simply kind, experienced, knowledgeable, practical and emotional support and care. So it was these qualities that informed our hospice at home service. We needed to find a cohort of people who could deliver that kind of care at that kind of time. So we built a service based mainly on healthcare assistants who were experienced in dying, but enhanced by some staff nurse support. And the staff nurse healthcare assistant mix were to be supported and managed by our nurse specialist team. We built a business case, we sought a commission, and in fact the commissioners were very supportive of any model that might reduce unplanned admissions very late in somebody's illness journey and might reduce deaths in hospital. And we had to recruit. And in fact, in those early days, our recruitment largely came from our existent hospice inpatient workforce, who were very experienced in dying. Nevertheless, the staff we recruited did require training not only in care of the dying, but also in managing dying outside of the security of a hospice or a hospital setting. So the trainers that we used were drawn not only from the experienced hospice inpatient staff, but also from district nursing and from a marvellous GP who was passionate about care of the dying, and from our nurse specialists who were more familiar with dying at home. We developed a referral process to enable anyone who was concerned about somebody who might be dying to refer to the team, and we advertised and promoted the service widely. And from day one, the model was and continues to be hugely successful in its mission, and it continues in this form today. For example, last year, more than 95% of people who referred to hospice at home for end-of-life care now died at home. So that's an enormous impact from that service. There have been challenges. One of them is to receive referrals in reasonable time so that the healthcare assistants and staff nurses can get to know patients and families and to really enhance care in the last week or two, not just the last days. And over time, the need for hospice at home services at home has grown. The team struggled also to support the advice and support when they needed it. And that led to our Step 2 service, which I shall describe next. So the next service we developed was a 24/7 telephone advice line, not only prompted by the needs of the hospice at home team, but also by the growing stretch of the clinical nurse specialist team and the recognition that they really couldn't see everybody who needed help, and that there were many calls where some simple, straightforward advice and direction was needed to enable the GP or district nurses to manage by themselves. They developed the service, or we developed the service, with help from partners in care. Again, we look to now hospital partners, as well as bereaved families, our community services, and GP and district nurse focus groups to ask what sort of crises are common or are hard in the last months of life. What crisis leads to unplanned admissions in the last months of life? What helps avert the need for crisis admissions? What kind of support would you need? All of this to help inform a business model and a business case for the commissioning of a service, and to advise us of what level of support expertise might be needed for such an advice line. So the feedback we got was really helpful, and it identified that needs could be pretty complex. So the commonest reasons for admission were the unexpected, the rapid changing of care needs, the development of deteriorating mobility, the development of incontinence, the development of cognitive decline and delirium, difficult problems. Inability to manage food, fluid and medicines reliably orally anymore, increased somnolence, which particularly alarmed care home staff, and particularly was quite a common reason now for admitting the frail elderly at end of life. Patients suffering increased symptom burden, particularly pain, breathing difficulties and uncontrolled vomiting, which could be sources of alarm. And there was also the complexity of whether or not the condition at hand was reversible, whether there might be improvement through hospitalization. And also the challenge of lack of advice, particularly out of hours, beyond just call an ambulance. All of the previous slide informed the development of the hospice 24/7 advice line. It took a year and a half to set the whole thing up. We needed to decide who the call handler should be, and we elected at that time for clinical nurse specialists to be the call handlers because we anticipated that the calls could be quite complex, and we thus needed to recruit 3 whole-time equivalent CNSs to supplement the nurse specialists we already had. We had to ensure that all staff felt prepared to care by delivering triage, assessment training, and to make sure that the advice that they gave was secure, was safe, as well as useful. And we required the commissioning of the service, but we got the commissioning of the service, and the service launched at the end of 2011. Service user feedback has been hugely supportive. People have really valued and experienced voice through difficult times. They've really valued a phone line that they can access easily with somebody wise and sensible at the end of it. The advice line has been able to help people source appropriate medicines, adjust doses, advise on increases and changes with confidence. And the advice line has sometimes, when needed, been able to find somebody to visit the home who can then speak to them to make sure that the advice and the way forward makes sense. Challenges for the advice line call handlers have been great. They've really suffered sometimes from poor information. Initially, they were unable to access any hospital or GP information. So for people who they didn't know, it was really quite difficult to know what was actually happening with the disease and whether they could give safe advice. They found at times that they were talking to patients who were evidently extremely ill, but were poorly prepared with expectations for resolution of problems completely unrealistic given how poorly they were. And they could also find themselves talking to a poorly prepared professional care team, for example, out of hours GPs whose instincts were to, if in doubt, admit. And they suffered sometimes from lack of availability of drugs in the house or the ability to access face-to-face advice or support. But all of this was actually very useful to identify because it meant that resolutions could be developed over time. And so over the course of the following few years, we have been able to gain commissions for development of information technology systems, which now allow us to read hospital notes and to read GP records so that we understand the basis of the conditions that give rise to the symptom issues that we're listening to. And we've been able to broaden staff training in response to care home, to advice line experiences, to GPs, to district nurses, and to care home staff with real examples of where there have been gaps to really help development of their own skills and knowledge in advanced illness care. And we've been able to improve communications between hospital and home by working with the hospital palliative care team to develop skills in the hospital to create much more useful discharge summaries, which tell us the important conversations that have been had, treatment escalation plans, and treatment ceilings. Extremely useful in crisis times. And then COVID took us by surprise in 2020 and had an enormous impact on people that we normally serve. So people with advanced progressive disease, as well as a whole new audience of people who suddenly became health vulnerable. And we really needed to make changes to cope with need. So we had to cope with a huge increase in calls to the advice line because people felt at sea, they weren't able to connect with their GPs easily. It was a struggle to access hospital physicians who were just incredibly busy at the time. They felt abandoned, and our helpline was a next port of call. And that required an increase in advice line availability and an extension of phone lines and an extension of CNS support. We had to adopt, by a second wave, virtual face-to-face tools because people really were missing face-to-face connects, and we couldn't deliver home visit face-to-face connects in the quantity that we'd done so before. And we developed web-based resources onto the hospice website, both to help patients and families with self-care and to help professionals with how to do things like writing prescriptions properly. We really enhanced our use of anticipatory prescribing with the support of local chemists, and we began to use volunteers to support the more stable on our patient list by doing follow-up calls to keep connected with people who were stable but poorly, and to monitor them, support them, advise them, and also to preempt difficulties and to refer them back into the hospice service when they became unstable or unsteady. We set up weekly care home virtual MDTs to support that workforce, and we collaborated with other charities and used local media to promote the idea of the compassionate community. How could you help your neighbours through difficult times? Some of the services that we adapted and changed in COVID times, we've maintained because they actually proved themselves to be very useful. So, for example, we've maintained the use of virtual face-to-face for bereavement support, and it's very, very well evaluated and makes it easier to reach more people for bereavement support. And hospice at home had to remodel in COVID times because hours and hours in a house was simply not possible when the virus was so active. So they narrowed their time in the house to 2-hour blocks, and actually they found that 2 hours is enough to steady a family and help them feel supported and secure. So they now adapted their models so that they do shorter visits and they can reach more people in a day, which has been really useful and has not led to any depletion in evaluation or results. We were excited by the stepping up of our communities who were so keen to support people, and we've developed a passion to maintain good neighbour initiatives so that we're involved in ongoing public discussion and public campaigns to really identify how communities can help. And we have evolved our new initiatives, particularly the volunteer support line that was so helpful alongside the advice line. We use it for people who have advanced progressive disease but who are currently stable, nevertheless needful of support, and our volunteers hold and support until more specialist support is needed, at which point they can refer back into the hospice services. And we've extended that initiative to include people who are in need of ongoing bereavement support. We've also maintained programs that we developed to teach and train family and friend carers, and we have developed carer support workshops to maintain that work. This slide summarises the difference that community services have made. We have reduced unplanned admissions to hospital in the last 3 months of life, and we have reduced dying in hospital, not as much as we would like, but nevertheless significantly. The national figures show a drop from about 58% to about 45%, and in our area we're aiming for 40%. People feel more secure to die at home now and better supported, and care home staff are more prepared to care until dying. We've got more advanced care planning established by hospitals and GPs, and we receive regular positive feedback from the bereaved, and I've included some of those bits of feedback. I've summarised some of the key messages onto this slide. For those for whom we can predict dying, what really helps? talking honestly about what is happening now and what is going to happen, a family and a community prepared to care, and a family and community who are prepared to care. Support, compassion and wisdom from those with experience of dying, and good symptom management if the cause is not treatable. My last slide shows a national ambition for end-of-life care as articulated by a service user, really just expressing that what she wants from end-of-life care, and this is what we continue to work to deliver. Thank you so much for your attention, and it would be lovely to receive some questions when we meet at the end of the talks.
So rightly said, we'll have the question and answer session towards the end. Now I'll move. Thank you, Dr. Karina Mijli. We'll move on to the third talk of the session. This is going to be by Dr. Ehsan Azhar. Dr. Ehsan Azhar is the Associate Professor and Medical Director at the Acute Palliative and Supportive Care Unit in the University of Texas in the US. Over to Dr. Ehsan Azhar.
Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. This is Dr. Ehsan Azhar. I am an associate professor at the University of Texas MD Anderson Cancer Center in Houston, Texas. I'm also currently serving as the medical director for our acute palliative and supportive care unit, and am one of the patient safety and quality officers at the institution. So first off, I want to express my deep appreciation and gratitude for allowing me to participate in this symposium as a speaker. Thank you to the organizers, Dr. Harun Hafiz, Dr. Atif, and others for providing me this opportunity. The topic or the title that I assigned to this talk today was Bringing Palliative Care to Patients. Primarily, we'll be focusing on description of different settings of palliative care delivery with emphasis on early referral to palliative care teams. I have no conflicts of interest to disclose. And as a disclaimer, just want to share with the audience that my current work at the medical center is primarily provision of inpatient palliative care services to cancer patients. In general, my exposure to community-based palliative care has mostly been during only my training, and most of the information is from literature review and discussions with our partners and colleagues who provide such care in community-based settings and through research with them. So without further ado, the educational objectives of this talk would be to describe different settings of palliative care delivery and how may these settings integrate to provide goal concordant care for our advanced cancer patients. What are the general myths and fears about palliative care, and identifying patients who would potentially benefit from palliative care and end-of-life care or hospice care. No talk can begin without the definition, and you are all very well aware. Palliative care is the care given to improve the quality of life of patients suffering from serious or life-threatening diseases, to prevent or treat as early as possible the symptoms, the side effects, and to assess psychological, social, and spiritual problems, and to mitigate or provide management in a timely fashion. WHO extended this definition to include families as well as a team approach to take care of these issues. So why palliative or supportive care? Of course, as you are all aware, patients with advanced illnesses have high symptom burden and low quality of life. The focus of healthcare is changing or has been changing from disease-oriented to a patient-oriented model. There are rising healthcare costs, which are a global issue, and more evidence points towards palliative and supportive care playing a positive and an essential role towards solutions. Again, the schematic you may all be very familiar with. The term supportive care, which is synonym to palliative care, is a relatively newer term and has been associated with less stigma. It is more hospital-based in most of the cases and has or provides wider range of services with less volunteer involvement and more so specialized employees. This could be named for the services which patients are receiving at a very early stage of their diagnosis into an advanced stage. Palliative and hospice care, these are mostly, their older terms have more stigma associated with them. In certain countries like the US are more home-based and may rely on volunteers. Another important element to always remember is that these services do not stop after a patient dies, but rather can continue in the form of bereavement services and psychological and social support for family caregivers. And ASCO, in their recommendations and palliative care guidelines, which holds true to even this day, provides recommendations for patients with advanced cancer, whether inpatient or outpatient, should receive dedicated palliative care services early in the disease course, as early as within 2 months, concurrent with active treatment. The guidelines encourage the oncology specialists to refer patients to interdisciplinary palliative care teams, where it may work and complement existing programs. And how does this all happen? What is that secret sauce or ingredient which brings this all about? So while the focus is improvement in quality of life for patients and families, it is not a one-person job, and it involves multiple specialists working together, as we will be talking later as well. And what do patients have to say about it? So in this abstract or poster presented at ASCO in 2017 by one of my colleagues, the survey conducted through our patients reported that most of the majority of the patients reported that they had a good referral in terms of their time. However, the surprising element was that over 20% of patients stated that they were referred very late to services like supportive and palliative care. And an overwhelming majority found the referral extremely useful and would recommend to their other patients or their family members if needed. So what are those different settings where palliative care can be delivered? Inpatient, where it is either a hospital or a hospital-like environment, an outpatient, which is ambulatory or clinic-based, and then a community-based. And multiple randomized controlled trials, and few are listed here, report that addition of at least 2 out of 3 care settings to routine care has shown improvement in patient care outcomes. Specialist palliative care involvement has positive impact on all the different outcomes like patient quality of life, symptom burden, as well as satisfaction. So going through the pages of history, we can see that at different timelines, back in 1950s and 60s, when Cicely Saunders started the hospice movement and coined terms like total care. And then later in the 70s, Dr. Belfort Mount, a surgeon in Montreal, coined the term palliative care for the first time and started the first palliative care unit, which basically was the beginning or the start of an inpatient care. And then over the decades, the inpatient palliative care continued to grow. Then in 90s, Dr. Eduardo Barrera, you see him here in the middle row in there, created the first outpatient palliative care clinic in Edmonton, Canada, and later at MD Anderson Cancer Center. So we see all 3 different facets or settings building or evolving over time. In 2010, everyone is aware of the landmark paper by Dr. Temmel and the group, which emphasized early palliative care involvement in improving patient care and quality of life. It is around the same time when the teams at MD Anderson were publishing opinion regarding the the term palliative care versus supportive care, and an overwhelming majority felt that supportive care was a better term with less taboo. And then in recent times, over the last 3 years or so, with COVID, the telemedicine aspect has really brought a new evolution in the delivery of care that we provide. Patient referrals used to be at very end stage of their life, in days to weeks, increased to weeks to months when the clinic model was involved, and now can even extend to months, even up to years. So in the inpatient setting, the predominant role or involvement of palliative care teams is in the form of consultation service. These provide recommendations for symptom control, assist with sensitive medical decision making, as well as facilitating complex discharges. Scott et al. In their 2020 systematic review, when they looked at the impact of hospital-based inpatient consult services on post-discharge outcomes and care, reviewed 15 studies over 53,000 patients, concluded that involvement of an inpatient consult service increased rate of community discharged, post-discharge care provision and coordination, and there were lower rates of readmissions. There are different tools which have been developed, which the emergency room teams can utilize for inpatient referrals, like the palliative care and rapid emergency screening tool for advanced cancer patients. If the patients meet at least 2 of the 5 criteria, they can be referred. Similarly, there are other tools that exist. And studies from the Al-Jawari team, she is a fellow of Dr. Temel, and looking at patient cohorts with and without palliative care involvement. In their initial randomized controlled trial back in 2016, they looked at patients with stem cell transplant, and the primary outcome was quality of life at 2 weeks and 3 months. And in their recent trial with leukemia patients on intensive chemo, they concluded that symptom burden, especially anxiety and depression, were better in palliative care group as compared to group on routine care. Now, within the inpatient setting, the other model or provision of the service is through the acute palliative care unit. Now, this is different from the consult service. Here in the acute palliative care unit, the supportive or palliative care team most of the times assumes the role of the primary team. This could be mostly at the end of life, in last days of life. And the objectives would be, of course, to provide clinical care, managing refractory, complex symptoms and complex discharge issues, as well as education of physicians and the disciplines, and doing research at this stage of life. Unfortunately, as per the recent census, only 40% of NCI designated cancer center in the USA have inpatient units. These units are designated beds within the hospital inpatient facilities. These are designed for terminally ill patients, not necessarily dying patients. Care is provided by highly specialized interdisciplinary team members, which are led by a palliative care physician, to address complex problems, offer full range of diagnostic and interventional procedures. However, the goal is to gear toward a palliative care, a palliation of symptoms, as well as availability of other specialty and subspecialty consultations. And some of these studies from our center, when the unit was started, concluded that the discharge outcomes were better when patients were transferred to the unit. Within a month, patients going or admitted at the unit underwent multiple interventions, including procedures. And there are studies which show that presence of in palliative care units with consultation services have shown statistical improvement in multiple outcomes, including better assessment of patients, improved symptom control, better family satisfaction, as well as utilization or bed utilization in the hospital, and decreased cost of care. Unfortunately, again, not all centers, cancer centers in the USA, are equipped with these units. The other setting, the outpatient setting, which is the ambulatory or clinic setting. Now, these are mainly for patients who are at early stage. They have a better performance status and a longer survival. And having patients come to this setting helps provide or build a rapport and opportunities for longitudinal care to relieve suffering, of course, to optimize symptoms, preparing patients and families for difficult times ahead in case their cancer is progressing, and also has shown to prevent hospitalizations. In fact, over the years, it is shown that now in 2018, the referral times are up to 6 months as compared to 3 months back in 2009. These clinics can be embedded within the hospital system or network, or could be standalone clinics within the network in the periphery. Again, the main mode of delivery of care is an in-person appointment, the conventional approach, of course, where patients come and visit these clinics and the specialists through an appointment. These clinics can be a point of contact for questions, medicine refills, and some of the add-ons to these conventional clinic models has been, for example, having a specialized nursing support telephone call line where proactive calls are made by the nurses in between appointments to check on the patients or after discharge, or also availability of walk-in visits where patients can drop in on the same day without appointments. In the retrospective study, which we published back in JPSM in 2018, showed that patients who present to our clinic as walk-ins without appointments had actually significant worse scores for pain, depression, anxiety, and other symptoms. Their OPR appointments were much higher, and those were the patients who were likely to live outside the greater Houston area. So if they were visiting the hospital for other appointments, they would take the opportunity to visit our clinic since that opportunity was available. These were established patients with us and would stay in touch, and when they were visiting the town or were having other appointments, would come and were able to avail that opportunity. And nursing triage helpline is able to serve 30 to 40% of our patients in helping with multiple symptoms. And these patients who use this program have worse physical and emotional distress compared to those who do not use this. So this is another element or area to review when developing care models. And the international consensus criteria for referral to outpatient palliative care as published in 2016 included 11 major criteria. 9 of these were need-based, while the last 2 were time-based when patients had limited prognosis or their disease was progressing despite second-line treatment. And multiple randomized controlled trials over the years have proven that compared to usual care, outpatient specialist palliative care was associated with significant improvement in quality of life. However, it was pointed out that depressive symptoms did not differ. So this was thought to be of an area of improvement. Looking at our center and team back about 4 or 5 years ago, we only had 1 counselor. And now we are recently hiring a 4th counselor and have about, I think, 6 PhD psychologists. So the growing demand and need of our patients has prompted to help improve the team and to fill these type of gaps. Such outpatient involvement early on helps reduce emergency room visits as well as deaths in the hospital or in the inpatient unit. And again, it was noted that patients who were first referred to palliative care as outpatients had better outcomes than those who were first referred as inpatient. In fact, in the study, a retrospective review that we performed at our center published in JPSM in 2021 showed that up to 2% of patients referred to our teams in the inpatient area are still being referred very late within 24 hours of their death. So early involvement has definitely merits and is encouraged. Now moving on to the community-based models. Here, the care teams tend to go to patient homes to conduct symptom and need assessments, provide recommendations for various non-pharmacological as well as pharmacological interventions. They may also assist patients with daily activities and offer counseling, as well as education for patients and caregivers to support self-management of symptoms, including self-administration of medications for comfort measures. Looking at the different models of community-based care that are provided in the United States, they are home health care plans, or hospital at home programs. These are acute hospital level services, including blood collection, delivery of intravenous medications, and other services which are geared towards more intensive level medical care, not necessarily focusing on palliation of symptoms or comfort, but more so towards cure and management of acute medical issues. These services may also have limited cover after hours. As compared to some of those hybrid models which were introduced or have been introduced in the community as community-based palliative care programs or home palliative programs, which can provide some of the acute medical interventions, however, while focusing on patients' comfort and quality of life and education of patient, family and caregivers. And then one of the model of community-based palliative care is the home hospice care or hospice care, which is definitely unique and different since it is the healthcare system has much different reimbursement policies, and it is mostly not concurrent with acute care, which means that patients need to forego any acute medical interventions or oncological treatments when they sign up with this community-based model of care, which is mostly end-of-life care and prognosis of 6 months. In the US, it's mostly home-based, while in other countries like UK and Canada, it could be a freestanding facility where patients are transferred near the end of life. And several systematic reviews on community-based palliative care do include hospice programs as well. So what is the difference between palliative care and hospice care? While palliative care is provision of services which are being received during with active medical intervention directed towards care of disease, so patient could be receiving active oncological care while focusing on comfort and quality, while hospice care is patients who are terminal, not necessarily dying, and have prognosis of less than 6 months, considered to have an advanced, progressive, and incurable or refractory disease. And the goal of treatment is relief of symptoms and not cure. Tests are limited or not performed anymore, and patients tend to be in an area where they're more comfortable, perhaps among their family, and with provision of some of those elements of care which they are required more towards the end of life. And as we know, patients who suffer near the end of life have multiple challenges. There is no defined timeline how to define the end of life care. The general terminology of terminal condition or end of life with incurable, progressive, advanced disease with months to weeks, weeks to days, and days to hours is something that defines this timeline. Non-hospital based models. So non-hospice based models in community, these are intended for patients who are typically homebound, have a poorer performance status and shorter expected survival. Now, these programs, again, as I mentioned, are some of those hybrid home palliative care programs where patients are still seeking active medical or oncological care, but these programs could serve as an alternative to hospitalization where many minor elements of care or issues could be dealt at home. Medical support is provided to patients who might otherwise need acute care visits to the hospital. So these visits could be limited. However, certain patients where symptoms are severe and cannot be managed in the community or at home will still require admission to a hospital. So having a connection relationship with a team which works either at the same hospital or in combination in partnership with them could also ease and facilitate transfer at a timely manner for better provision of care. And multiple randomized trials, again, in a 2013 Cochrane review, having systematic review and meta-analysis of 23 studies, 16 of them were randomized trials looking at 37,000 patients and 4,000 caregivers, showed that community-based palliative care was associated with more home deaths, meaning less hospital-based deaths, and better symptom control than usual care. And again, a recent systematic review looked at 19 studies, over 92,000 participants, comparing the usual care with community-based palliative care, showed reduction in hospitalization, shorter length of hospital stay, fewer emergency department visits, more home deaths, meaning reduction in hospital deaths, and lower costs of care, of course. So who performs all these care plans. There is a medical director, which is mostly a physician in the background for such a community-based palliative program. Certified community team members, physicians and nurse practitioners certified in providing palliative care. Nursing team members who may include wound care specialists. A manager and coordinator is essential and vital. Nursing or health aid team members, spiritual support staff, social workers and volunteers, and many other ancillary healthcare team members, including phlebotomists as well, may be a part of this team. So when these community-based models are introduced and patients and families are given that opportunity or option, many questions may arise. Some of these may be myths, others may be facts. So for example, some of the things that come across or are asked by patients and families from us when we are transferring them into community-based programs is, does the patient need to be a DNR? Not necessarily. However, there needs to be a detailed discussion about goals of care and what are their priorities. Will I need to leave my house and move to another facility? Not necessarily. Again, in the US, hospice is introduced as a care plan, and the patient chooses to receive this plan at a place, mostly home or home-like setting. However, inpatient facilities are available, but they are not that much popular or widespread. Is community care expensive? And again, here, this care is actually covered under the Medicare benefits, and hence it is actually very low cost to the patients. And answer to this question will differ from area to area geographically. Will myself or my family have no say in making treatment decisions? This is an important concern and consideration regarding shared decision making. I will not be able to go out of house or travel. Now, again, based on patients' performance status, we in fact share with our patients based on feedback from patients who have been transferred to community care programs where they can save time and energy by having to visit or transfer to hospitals and waiting in the emergency room or waiting areas in the clinics, and can in fact spend some of that energy being more mobile around the house or travel and so on. Many of these patients have long-term relationships with their oncologists, and they're concerned about discontinuing that, so that has to be addressed. Will community care provide antibiotics or check my blood sugars, provide IV hydration or blood transfusions? I will not be allowed to continue physical therapy and occupational therapy. So again, for some patients, this may be an important element. Another huge concern could be there will be strangers coming in and taking over my house. So privacy issues and security issues and concerns from family members that my patient will be left on the mercy of untrained staff or volunteers. So that reassurance need to be there from the very beginning.
Due to the time constraint, I'm just going to stop here. We'll have this talk later on uploaded, so you can have a look. So we'll move on from west now to east. We have got community palliative care services well established in Karachi. So I'm going to ask now Dr. Mohammad Atif Okar to tell us about the services that they have there. Dr. Mohammad Atif Okar.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everyone. Thank you so much, Dr. Atif, Dr. Kashif, and Dr. Haroon for inviting me and giving me this opportunity to talk about community-based palliative care services in Pakistan, something that I'm very passionate about. In fact, before moving to Pakistan, in the US, I was the medical director for the home-based palliative care program over there. And we've brought some of those learnings back over here in Pakistan. Just a slide on my disclosures. I've got no conflicts of interest and I've got no relevant financial relationships to disclose. In the interest of time, what I'm going to try and do is I'm going to skip over some of the slides because it's going to be a repetition and duplication. Our previous speakers have covered that in great detail. What I'm going to focus on is exclusively Pakistan. Where do we stand in terms of the current landscape? How well developed are community-based palliative care services in Pakistan? What are the challenges that are unique to us, not just globally? And then if time permits, then I would love to share with you how we set up our palliative care service in the homes for patients in Karachi. So these numbers, as we know, they're underreported, criminally underreported. For the purposes of this talk, unfortunately, these are the best available literature that we have. So it's estimated that about 180,000 patients are diagnosed with cancer each year in Pakistan. And we know that 120,000 will die from cancer each year. So essentially what we're saying is that 58% mortality, these are all patients that would benefit from palliative care services before they die. This is actually a need assessment that was completed by the Lancet Commission on Global Access to Palliative Care. And they estimated that in Pakistan, the total number of patients that are in need of palliative care is 868,000 patients per year. Of that number, you can see over here, the top 5 diagnoses for patients that require palliative care, of course, malignant neoplasms is at the top of the list. And they estimated that 187,000 patients are in need of palliative care who have malignant conditions. When we look at how developed palliative care is in Pakistan, then Pakistan is categorized as a level 3A country. And what that means is we've got very isolated provision of palliative care. Palliative care services are very sporadic, they're underdeveloped, and relative to the population of Pakistan, the number of specialist palliative care services are very small. So if you look at the numbers over here, for every 90 million of our population, it was estimated that we had a single specialist palliative care service. They also estimated that less than 1% of our population has access to palliative care. We're not saying that they receive palliative care. They have access to palliative care if they choose to receive palliative care. And so what are the challenges when we start to develop a community-based or palliative-based service for our patients in Pakistan? And of course, much of that goes back to expenditure. 87% of all healthcare costs are paid out of pocket because patients refuse to go to the public sector hospitals because of the abysmal care that they receive over there. Unfortunately, because of that, there is a huge out-of-pocket cost. And patients, often their family members ask us, so now we have to pay to die as well? And it breaks our heart when we have to answer that question. We don't have health insurance over here that would cover the cost. We don't have employer benefits. Employers don't cover medical benefits for the most part. Old age benefits do not cover medical care. The very few health insurance companies, they will cover inpatient care, but they will not cover home-based care. So then you're struggling. How do you provide care to these patients? And what the worst part is, 45% of our population is living below the poverty line. And looking at those numbers, the recent census of Pakistan that was just published, our population is now 241 million. And of that 241 million, 8% of that population is of the geriatric age group. And there's a huge tsunami of geriatric patients that are going to be entering into the healthcare system. They estimate that by 2030, 16% of our population is going to be of the geriatric age group. These are all patients that are going to desperately require community-based palliative care services, but we're so ill-equipped, we are not going to be able to handle the influx of these patients when they enter into the healthcare system. What's worst is what we're seeing now. Because of the economic climate in Pakistan, many of the skilled workforce is going abroad. And we're seeing this in every other home, the empty nest syndrome. They're leaving their parents behind, not because they want to, out of necessity. They're going abroad and they're leaving their elderly mother and father over here, and they've got no one to care for them. And those are the patients who are going to require strong support in order for community-based palliative care to thrive. So now, specifically talking about community-based residential palliative care programs in Pakistan. So I'm sharing the data from the Atlas of Palliative Care in the Eastern Mediterranean region. Dr. Harun was instrumental. He was the country correspondent for this publication. And at the time when it was published, so you can see that in Pakistan, home-based palliative care services were 0. Nursing home-based palliative care services, we only had 1. And we had 5 standalone hospices at that time. Now, the reason I'm also sharing with you side-by-side comparisons from Saudi Arabia, Egypt, and Iran, so that we can demonstrate, look at the population over there. So 31 million in Saudi Arabia, and they've got 8 home-based palliative care services compared to, at that time in 2017, 188 million of our population. Look at the numbers, they just don't match. So what we tried to do, since these numbers are dated, is we wanted to see where do we stand today? Because we know, alhamdulillah, we've made strides. There have been changes. There have been new home-based palliative care services that have arisen since that time. So we tried to map out the community-based palliative care services in Pakistan. Now, mind you, we are not including any hospital-based palliative care units. We're not including any hospital-based consultation service or outpatient clinics. This is purely community-based palliative care services. So you can see in green, we've got the community-based palliative care services and the geographical distribution right now. And the residential hospices, the standalone hospices right now, we've got a concentration over here and then some over here. Now, this by no means is an exhaustive list. This is based on the best available data and the information that we were able to gather. So I apologize if any of the institutions got missed over here, but this is essentially what we were able to find. And it was my privilege a couple of weeks ago when I was very kindly invited by our colleagues at Shaukat Khanum, Peshawar, and they shared with me the home-based palliative care service that they had set up, state of the art. The operations, the way that they are structured right now was very impressive. And kudos to you and your team for starting such an innovation here in Peshawar. But when we talk about the challenges and the resources in the community, Dr. Lowry and Dr. Bijli already talked about it. You need 2 things, very important. The first thing is you need a pool of trained volunteers. You need a network. Without volunteers, you can't run home-based palliative care services. And unfortunately, in Pakistan, we have a lack of that. Another thing that many countries have done is they've piggybacked off of home health services, and they have added a wing for home-based palliative care services. But again, in Pakistan, even home health services are neglected. Now, the good thing about COVID was because of COVID, we did see that home care services started to creep up, and patients were starting to receive home services. Home health agencies started to develop in Pakistan, and that's a positive thing. But in terms of nursing homes, we've got very few nursing homes in Pakistan. The few that we do have, they're faith-based nursing homes run for the Christian community, the Parsi community, the Ismaili community, and they cater exclusively only to their own community. So it's not open to everyone else. Why don't we have nursing homes in Pakistan? Because of that myth. The way that our cultures and our values dictate that it's considered dishonorable or disrespectful if we send our elders into nursing homes. We're supposed to be caring for them at home. But the problem is sometimes their care needs exceed what we can safely provide for them at home. But because of that honor, we try to continue to provide care at home, and we're doing a very bad job at that. In terms of institutional support, again, there's very limited institutional support, and the reason being, institutions look at the bottom line. Are we going to be able to generate revenue? And if we're not going to be able to generate revenue, they're not very interested in starting new services. Historically and traditionally, palliative care services have always been cost-saving models. They've never been revenue-generating models. So by providing palliative care, we're saving soft dollars to institutions, to patients and family members. And that is something very difficult to sell to administrators in the institution. And the other important thing is the referral system. Home-based palliative care, this is a subspecialization. You won't have your own patients. Unless patients are referred to you, you won't be able to build up a practice. So you need to have a very strong referral system. And again, the problem in Pakistan is patients are considered to be a commodity. If I refer my patient to this service, then they will steal my patient and I will lose business. Therefore, I will retain the patient. I will not refer them, even if it means that I'm providing very bad care to them. That's just the reality. And then, of course, the struggle with controlled substances, as the previous speakers have already shared with us, controlled substances being dispensed, being procured in Pakistan, that in itself is a one-day lecture that we can talk about. But in the interest of time, at least I want to share with you a couple of slides, very important slides. We know that we've got very limited opioids in Pakistan. Even the ones listed over here, at least we don't have in Karachi. Transdermal fentanyl patches, that was a luxury we had for a few months back in 2018. The company Novartis and Sandoz, they found that it wasn't profitable and they closed business. So essentially all we've got is long-acting morphine. We don't even have intermediate-acting morphine. But what I wanted to show you is actually the opioid consumption in Pakistan. So I'm showing the data from the Eastern Mediterranean region. So you can see over here in the Eastern Mediterranean region, the maximum consumption of opioids per capita is 33.5 milligrams. The median consumption of morphine is 3.27 milligrams per capita. Now look at Pakistan over here. It's 0.05 milligrams per capita consumption of morphine, which is very, very distressing. Another very important diagram that I wanted to share with you is this map. This was also taken from the Lancet Commission on Access to Palliative Care. And I'll explain to you what they're showing. Basically, they have inflated or deflated countries depending on how accessible opioids are for palliative care patients in those countries. So to give you an example, let's look at Canada over here. So in Canada, what they're saying is that every patient who is receiving palliative care and in need of morphine has access to 68,000 milligrams of morphine per year. Let me repeat myself. Every patient on palliative care in Canada has access to 68,000 milligrams of morphine per year. Now compare that to Pakistan and Afghanistan over here, where it is a maximum of 4 milligrams per year that is accessible to the patients who require palliative care per year. And I'm sure the irony is not lost on you that all of the raw material to produce the morphine, the opium, is harvested at the border of Pakistan and Afghanistan. But look at the disparity that the medicinal properties of that opium, unfortunately, were deprived of. And then Dr. Laurie talked about this very important advocacy. Without advocacy, you will not be able to send the message across. Something that we're doing today, alhamdulillah, we're having this discussion, but what you need is a national palliative care policy. We don't have that in Pakistan. In Pakistan, we don't have laws or legislations for DNRs. We don't have laws or legislation for advanced directives. The DNRs that we have in our hospitals, those are institutional policies. As soon as the patient leaves the four walls of your hospital, that DNR has absolutely no legal standing. How are you going to care for patients at home then? And then the struggle is, in Pakistan, we don't have any national palliative care association. We don't even have a regional palliative care association. And without these associations, advocacy for palliative care cannot move forward. And then in the Cancer Symposium last year, we covered the topic of training and education in detail. And all of us are very familiar that there's a dearth of trained palliative care healthcare providers, allied disciplines, nurses, and physicians in Pakistan. Without skilled workforce, how can you provide palliative care for patients in the community? So I'd like to share a little bit about our palliative care service at Aga Khan University Hospital, a little bit about Aga Khan University in Karachi. We are receiving the highest acuity patients, the most medically and psychosocially complex patients are received throughout Pakistan. In fact, this is like the final destination. They usually go to all of the other hospitals. Once their patient starts to deteriorate and get worse, then they bring the patient to us, many times in agonal breathing. They're gasping when they come to us. Most of the patients that we receive with oncological diseases are received at very advanced stages. Approximately 60% of them are coming at stage 4. Alhamdulillah, at the palliative care services at AKU, we've got it integrated at every level. So we do have a palliative care dedicated admitting unit. We've got a consultation unit service. We've got daily outpatient palliative care clinics. We've got palliative care integrated into the curriculum, both at the undergraduate and the postgraduate level. And we also have a very robust home-based palliative care service. So our home-based palliative care services, it started in 2002, very humble beginnings. Believe me, we had a senior medical officer who was part-time, who would make home visits for our patients. And we had a couple of nurses. Gradually, then it went up to 4 nurses, 6 nurses, and we built on it, but it was very small gains that we were making until 2015. In 2015, we went back to the drawing board and we re-engineered our complete model of providing home-based palliative care. And what we opted for was a hub and spoke model. So Alhamdulillah, with the Aga Khan University, we've got collection centers throughout Pakistan, everywhere. And in addition to those collection centers, we've also got community-based Aga Khan clinics. So we started to designate them as the spokes. And the hub became our main Stadium Road campus of Aga Khan, where we had the primary palliative care team and the unit. And everything was connected through that. Once we started with the hub and spoke model, our census started to grow. Our numbers of visits started to grow exponentially as well. So Alhamdulillah, now we have 325 healthcare providers that are providing home visits. In the last year, in 2022, we did 93,000 home visits just in 2022. So Alhamdulillah, we've come a long way through that. Karachi alone, if you talk about it, it's a mega metropolis. In Karachi, the population based on the census right now is 30 million. So they've divided Karachi into 7 districts. In each one of these districts, based on the geographical locations, we've got different catchment areas, and we have designated teams in all of those locations. And we're providing palliative nursing, physician, and rehabilitation services as well. So a little bit about our service. I modeled it according to the US home-based palliative care services based on the Medicare model of home-based palliative care services. So what we do over there in the US, it's standard of practice. The MDTs are actually fortnightly, not weekly. And that's the practice that we're doing over here as well. When our patients require hospitalization for inpatient hospice care, end-of-life care, or they have intractable symptoms that can't be managed at home, we're bypassing the ER, we're directly admitting them to the palliative care unit in the hospital. We've got real-time coordination between the home-based palliative care team and the hospital-based palliative care team, and the communication is happening in real time through various different platforms. We had to come up with dedicated transportation for our staff. There was no other way that we could do this. So we have our own vehicles, we have our own transportation. They are picking up the patient, the staff from home, dropping them at the patient's home, then picking them from the patient's home when their shifts are ended, and they're dropping them back at their own home. When we started off, we were just doing procedural visits. So we were doing skilled nursing care, putting in a Foley catheter, pulling in an NG tube, starting an IV cannula, doing hydration, infusions. But then over time, with the growth of our program, now we're providing around-the-clock care, 8-hour shifts, 12-hour shifts, even 24-hour shifts. We're doing that as well. We are providing durable medical equipment so that anytime our patient has a change in condition and they need oxygen, they need nebulizers, they may even need BiPAP for air hunger and distress, we'll immediately provide the equipment to them and we'll get it in their homes. Whenever a medication needs to be started, our pharmacy will dispense the medication, we will transport the medicine, we will deliver it to the home where our staff will administer the medications at the home as well. Just recently, 2 months ago, we've even started portable imaging, and now we're doing x-rays and we're looking into feasibilities of portable ultrasounds as well. The goal is, if there are any symptoms that can be alleviated before we transport the patient to the main hospital for intervention like a pleural drain or an ascitic drain, can we at least confirm what's going on and whether or not it's going to be feasible for us to do that? We are doing home phlebotomy for patients whenever periodically they do need a test to be done. We are doing continuous infusions as well. Instead of syringe drivers, we've got infusion pumps, and we've got them in ample amounts. So we're doing all of the infusions at home. We are providing close to 64 different skilled nursing procedures at home. Up to 2 years ago, we were not able to cater to pediatric patients. We didn't have the necessary skill set, but now we are providing pediatric palliative care as well, both nursing and physician pediatric palliative care. And we've started to cater to a more higher acuity level of patients that require care that is sometimes equivalent to what you could expect to be delivered in a high dependency unit. We're doing some of those interventions at home as well. So this is the core team that is providing the home-based palliative care. We've got, Dr. Atif, we've got 5 consultants, I'm sorry, not 7. So 5 consultants full-time. All of them have underlying specialties. We're from a very diverse group. We draw off of each of other's strengths, but each one of us is boarded and certified in palliative care. We're all trained in palliative care as well. Having said that, none of the faculty members makes house calls. The house calls are still made by our fellows and dedicated senior medical officers, but they report to us. And the treatment plans are overseen by the faculty members. We've got clinical nurse specialists, nurse navigators, clinical nurse instructors. We've got a dedicated nurse just to do wound care. We've got nursing staff from different cadres. So we've got registered nurses, of course, but patients who require lesser skilled level of care, we've also got nursing technicians, and we've also got HCA, healthcare assistants, who just require custodial level of care. They don't require skilled nursing of care, and the physiotherapists. Now, part of the extended team, we've got dental hygienists and speech therapists. They are making house calls. The dietitian and the psychologist, they are not making home visits, but they're providing televisits to patients who require them. So what was the impact of our home-based palliative care service? There was a seamless transition of patients from the hospital to the home. All of our end-of-life care outcomes improved. There was increased death at home, which for us is actually a quality indicator. We saw that expected mortality inpatient in the hospital fell down because these patients were moved to the home and supported to die at home with dignity. The length of stays went down. Our 30-day rehospitalization visits also went down because of the home care services. The bed occupancy was reduced. We were able to decompress the hospital. Previously, the ER was always on diversion. and we couldn't accept patients. But now the occupancy and the bed turnaround was increasing. The bed flow was improved. Satisfaction scores for patients and families also improved. And of course, it was more cost effective to provide this level of care at home rather than providing it in the hospital. But it came with a lot of challenges. This is my last slide. I promise I will shut up after this. But the challenges were tremendous. Something that Dr. Atif was just sharing with me right now was staff security. Big challenge. In Karachi, unfortunately, crime is rampant. So what happens to our staff if they get mugged during transportation to the patient's home? What happens to them when they're in the patient's home? Because again, we've got male and female staff members. And the female staff members, we've had many instances where there were threats of harm and injury to their lives. Now, just imagine yourself in Pakistan, because we've got extended family members, dying patient at home, you've got one nurse or one doctor making a house call. The entire family member is surrounded. They're looking at you, they're staring at you, they're criticizing everything that you're doing over there. You feel very threatened in that moment. In the hospital, we're practicing in a very safe environment, but at home, we're left to fend for ourselves. So there were instances where people even threatened our doctors and nurses that I'm going to put a bullet through you if my mother dies right now. So it becomes very difficult and very challenging. There are certain red zones, Korangi, Orangi, Leari. I'm sure you've heard of these areas. This is where gang wars are rampant. So unfortunately, these are red zones. We're not able to provide services in these areas. And then parental controlled substances, doing them at home is very difficult, very challenging. The expectations, suddenly the patient starts to deteriorate and the family members demand, we need an urgent visit right now. In the middle of the night, they will say they want to visit right now. It's hard to meet with those kind of expectations. The demand for the services is so high that often we're not able to provide those services. So we have to refuse services because we just don't have the staff. Sometimes we've even had to put them on a waiting list, and we let them know as soon as the staff becomes available, as soon as there's an expiration, we will reassign the patients and the staff to your patient. And then staff transportation is a big challenge. So I just shared with you now, when you're providing 24-hour care, let's assume 24-hour nursing care to one patient, that's just not one nurse. You have to think of it 8-hour shifts. So you're looking at 3 nurses. Then you're also having to give them days off for weekends, for holidays. What if they get sick in between? How are you going to provide cross coverage? So a single patient, you're actually looking at sometimes 5 to 6 nursing staff for a single patient. And then staff attrition and retention. That is a big challenge because there's a lot of compassion fatigue, caregiver burnout, stress. The kind of work that we're doing is very emotionally depleting. So people, they do this for a year or 2 years, but then they're not able to continue long term. So we've had staff turnover. We've lost a lot of good staff. And then the last point, of course, is none of this is free. It's all out of pocket cost. And unless they can afford nurses' visits, doctor visits, home-based palliative care services at home, unfortunately, they're not able to get the services that they require. So with that, I've come to the conclusion of my talk. Thank you very much.
Thank you very much, Dr. Atif Waqar. That was lovely talk. With this, I just got a couple of minutes if we have any burning question. So we had one question from online, and they were asking about what we are going to do for developing the volunteers, training the volunteers. So I'm going to answer that question later, but that's one of the things that's in our agenda. So I'm going to ask Dr. Abdul Jalil Khan to work on it from the university perspective, and we are going to work from the hospital perspective on that. Have we got any questions? If we do not, we have got the plenary session that has started. So if I can request the audience to join, I am very thankful to all of you. I'm very thankful to Dr. Abdul Jalil Khan for joining us, and Dr. Muhammad Atif Wakar for joining us, and also Dr. Harun Hafiz for helping me in this session. Thank you all.